I think this is a question that is equally complex with MR than with CT. I think with MR, the current size of the MR pixels are probably insufficient to reliably state MR can map channels of gray zone within dense scar in VT. I don't think it's true. I think 80% of the patients that enter a VT lab are patients with old infarcts where the wall can be as thin as 1 to 2 millimeters, and you can't image these walls with 1 to 2 millimeters pixels because you will have partial volume averaging and you will describe this very dense scar as gray zone. You're making mistakes. So we have a big issue of spatial resolution to detect the arithmogenic tissue with MR. And with CT, it's another issue. We would have the spatial resolution, or at least a bit better, because it's 0.5 millimeter for now. But the problem is that we have a lot of noise. So the way to threshold this signal in order to define what's gray zone, what's dense scar, is less robust than what can be done on MR. So I think both techniques should improve, and there are currently a lot of work improving MR in its ability to map the scar at high density, and particularly to robustify these thresholds for dense scar and gray zone by using extracellular volume mapping to calibrate the late guide enhancement dynamic. And on CT, there's this very new development in photon counting CT that may very well change the game, because for the first time, we will have pixels of 100 micron in humans in vivo to characterize the myocardium. And this may unravel a new set of knowledge with respect to ventricular tachycardia and AFib, obviously.